for symptom changes. Funding. What will the program cost? I had a conversation earlier today about how, can survivors afford it? How much less are they making, and how much did they pay for their cancer treatment in the first place? So they can't take another financial hit for this. In the 2 years since we finished PAL, we've done a number of formative assessment activities, including some focus groups with survivors that showed major themes. They're very concerned with safety of exercise programming. They're concerned with cost. They're concerned with the appropriateness of the programming given their cancer history and their treatment and their specific health risks. Because, as you all know, having a diagnosis of cancer is not a get-out-of-jail-free card for all of the other common chronic morbidities that are out there in our populations. Training of the staff, privacy, not wanting everyone in the fitness center to know that they're a cancer survivor, fear of lymphedema, onset or worsening among breast cancer survivors, and they want to know that their oncologist and their family feel that what they're going to do at the YMCA, at the cancer center, wherever they're going to do it, is safe. We do need to build appropriate fitness staff training. There are efforts afoot by the American College of Sports Medicine to try to do so, but one other alternative in what we're left with in the face of this sort of vacuum of not having a fitness industry that is ready to meet the needs of this growing population is to try to find programming alternatives that allow us to teach PAL or things like PAL to survivors that do not require that we send them to untrained fitness trainers. The further thing is that relationship building with the clinical oncology community takes years to do. It takes, and scalability of this is very difficult. If a fitness trainer came to any of the medical oncologists sitting in this audience today and said, I want to do a program, what is it you want to know from them before you can refer your patients to them? Would you give them the time of day? Do you value this? There's a number of things that, and who should they be talking to? Your oncology nurse practitioners, your PTs, the medical oncologists, the secretary, who should they talk to? There is this national effort afoot, the National Live Strong at the YMCA effort, and the issues that I am outlining for you here that I've experienced in the PAL and that it was experienced at the Burlington County Y, which was part of this Live Strong effort, is repeated. These issues are repeated all over the country, all over the United States. So what do? How do we disseminate this? The idea here is that we need to find ways to identify and develop effective communication channels and systems for safe and effective dissemination by identifying some social system out there with the appropriate leadership and expertise through which that communication can occur. And what we have decided to try at my institution is to use the Cancer Center as this bully pulpit. Because the survivors want the assurance and approval and endorsement of an oncology clinician before they start doing this kind of programming. So here's what, it's a really ugly green, sorry. It didn't look like that on my screen. You know how that happens? Things change. Okay, so what we're going to try is we have a breast cancer survivorship clinic, and we refer our breast cancer survivors to go see an oncology nurse practitioner. But if they insist on seeing their medical oncologist, that's fine too. Either way, the oncology clinician refers a woman who is done with her treatment to a physical therapist for a follow-up visit for evaluation for any of the common arm and shoulder morbidities that they may have as a result of having gone through breast cancer treatment or may have pre-existed their breast cancer treatment. We are talking about older women. Then the physical therapist screen and then treat if necessary for any of the arm or shoulder issues that might be there. Clear for exercise. So it's possible that this is where things stop. There's sort of a triage point at this point. But if they clear for exercise, the physical therapists then teach the intervention itself, okay, in 4 group physical therapy sessions. And we have managed to get the bean counters where I am to agree to charge third-party payers. And Medicare is agreeing to do this as well. They teach the PAL intervention in 4 sessions, and then they provide the women with a coupon. They get a coupon for one of 2 things, either a 3-month free trial membership at a YMCA, where they would go and then, we would work very briefly with the trainers to make sure that the trainers just knew the very, very, very basics of what they needed to do, or we will give them a coupon for a discount for home equipment for some adjustable dumbbells called power blocks that go from 1 to 33 pounds. Step 3, the coupon gets redeemed and the exercising begins. This is where the behavioral scientists in the room need to help me, right? So, will they actually do it? If you build it, will they actually do this? And then the 4th is vital, and that is that the women are taught what to do if there is a change in symptoms, if they have some new swelling or a new arm symptom, who it is that they are supposed to call in order to get evaluation and treatment and then have an appropriate return to exercise. Testing this approach means evaluating the acceptability, adoption, implementation, and maintenance by oncology clinicians, by the physical therapists, by the YMCAs, by the women themselves, by the in-home equipment providers, to assess the fit of this approach. Maybe this will work. Maybe it won't. Maybe it would work here and it wouldn't work at Penn. I don't know. We're going to find out. We're going to start trying this. If it works, we will attempt to disseminate it more broadly across the 8 Livestrong Survivorship Centers of Excellence funded by the Lance Armstrong Foundation and beyond. And as I said before, we think that this might have some cost-effectiveness potential, given the fact that survivors with lymphedema have double the medical care costs of survivors without lymphedema. So, in summary, what I'll share with you is that I think that community-based exercise is a good idea, but it requires an infrastructure that we don't currently have. You don't have it here. We certainly don't have it in Philadelphia. Based on my meetings this morning, you don't have it here yet. The Livestrong at the YMCA program is not the full answer. It is not going to do it because those trainers turn over too quickly, and getting them the next round trained is just going to be burdensome beyond belief. We do need to educate the Ys, however, about the needs of survivors. So there needs to be a sensitivity to the fact that a woman who has recently had a mastectomy may not want to change in a room full of young, able-bodied, able-breasted women. Connecting oncology clinics with YMCAs and other community organizations where exercise can occur is a big challenge, and figuring out how to do that is sort of the next step in serving the needs of this growing population. The sense of safety, survivor sense of safety, has got to be considered for scalable dissemination. Have you noticed that breast cancer survivors talk to each other? Does that happen here? Mm-hmm. Yeah. I think it probably happens everywhere. They talk to each other, and if your program hurts somebody, they're going to find out about it pretty quick, right? So my final word to you all is that it is my belief that the clinical oncology community plays a central role in making rehabilitative exercise programming available to all breast cancer survivors. And that we have a challenge in front of us that I think is not going to go away, and I think we're making some headway in trying to develop the collaborative care models that will someday create a situation where it is standard of care for breast cancer survivors to be referred for physical therapy evaluation, to be treated if necessary, and to be provided instruction so that they can return to full wellness at the end of their treatment. Thank you so much for your kind attention.
Thank you very much. First, I'll ask if there's any questions from the other centers all over BC, so I'm just going to unmute this. Unmute you. Any questions? Okay, no, I'm going to mute you again. I guess there's going to be questions here. Yeah. I just had one question to start. In your PAL trial, were there any significant adverse events with any patients? Like I understand as a mean people did well, but in any individuals, were there any particular adverse events?
Yeah. So the things, this is, goes into the lessons learned thing, and it's, with word limits of, whatever for the journals, you don't get this. It's difficult to know kind of where to publish this. The biggest lesson learned was with a woman who already had lymphedema to begin with, and who but was a former athlete and was used to pushing herself. And she came in and she had not exercised in a long time, and she had changes in symptoms right away. with really, 1-2 pound dumbbells doing upper body exercise. And she kept insisting to us, no, it's fine, it's just muscle soreness. And, one of my very best trainers was her, somebody who's still, working closely with me on this research, was her trainer. And she kept kind of shaking her head and saying, I don't know. And within 2 weeks, she had just had a massive flare-up, and she was never able, she came back 3 or 4 times and was never able to stabilize the arm during the entirety of the rest of the study. Mm-hmm. So I think that, we had, but I can count those on one hand. And mostly what we found was that women who did not pay attention to the change in symptoms and women who were irregular attenders, who came, regularly for 2 weeks and progressed and then went away for a week and came back and did not back off on the weights, those were the women who had problems.
Okay, thanks.
So,
that's helpful. Stephen.
So I'm interested in in your group of women that had lymphedema that were randomized to the control group, the non-exercise, that long, slowly, whatever. Mm-hmm. What percentage of them, because, there's a selection bias in why women would want to participate in the trial.
Right.
They're motivated, clearly. They have lymphedema. And they believe that perhaps that exercise would be a benefit. How many of them, quote, contaminated, did their own exercise? And maybe that's why they had such a high 30% flare rate, because they pushed themselves, because they got randomized to control group and not the exercise.
There's no way that I can ever guarantee you that didn't happen. But what I can tell you is what we did empirically in order to address that possibility. First off, we told them that, we wanted them to not change whatever exercise they had been doing when they entered the study, and please not to start doing any strength training. We also used the changes in strength as an objective measure of whether the women in the treatment group had been doing more strength training than the women in the control group. And clearly we have large, highly statistically significant differences in strength improvement in the treatment group than in the control group, which supports the contention that they did not do strength training. In addition, we also used several exercise surveys, one called the IPAC and another specific to strength training, to ask about what they did during the trial. And one of the things that's difficult is, they're not rats, they're human beings, they're going to live their lives, So, we told them also we didn't want them to go on any weight loss programs because we know that obesity is associated with lymphedema progression as well. But of course people did. People started taking, their Ally and, some of the other drugs that are available out there. So we collected information about any changes that they made in their health behaviors and weight loss changes during the study. Finally, we also had an injury survey. And the injury survey was worded in such a way that it was a sneaky way for us to find out exactly the kind of information you're talking about. We were trying to find out what kind of injuries they had and what kind of activities they were doing when they had that injury. And one of the things they could report was strength training. So I've just reported to you 4 ways that we went about trying to address that issue.
One other quick, just more comment. How about the development of an instructional DVD that will help to aid patients so you rely less on training?
No, on YouTube.
Yes. Yes, exactly. So we actually I'm in conversation with, turns out that somebody high up at Comcast, which is the corporate offices are in Philadelphia, is a breast cancer survivor, and we're going to start building a DVD. There is actually a DVD available already on the market called Strength and Courage that is quite well done and that focuses on very, very light weights and is quite safe. It is not the PAL intervention. I think it's safe, but it's not going to get the same effects because it's not progressive. So I think that there is the potential to do that, but not without some supervised exercise instruction prior to starting that. The question is, how little supervised instruction can we get away with? That's sort of the next question for me to try to answer.
Well, I think we've exhausted our time. Oh, Susan, do you have one last question? Yeah.
Yeah, I read years ago, and I cannot no longer find a paper that 10% of new cases of lymphedema are due to recurrent disease, and I've known that anecdotally. I would think if you're following 300 women with
Yep.
breast cancer for a year,